Welcome to this session in conversation with Professor Sir Jonathan Van-Tam. Sir Jonathan is a clinician and Deputy Chief Medical Officer at the Department of Health and Social Care. He has become somewhat of a household name during the pandemic and is famed for his clear explanations of graphs and figures, his sound reasoning, as well as his wonderful analogies, including train analogies. He was recently knighted in the 2022 New Year Honours List for services to public health. Many congratulations, Sir Jonathan. This question and answer session will be led by Dr. John Buchanan, who will pose questions that have been submitted by our students and staff.
Sir Jonathan, thank you so much for joining us today. We've had an enormous amount of interest and lots of questions have been posed to us for you to consider, if that's okay. If I start by saying East London has been particularly affected by the pandemic, our first question considers susceptibility to a severe outcome following COVID-19 infection. And one of the questions relates to how COVID-19 affects different age groups, ethnic groups with different genetic makeup, for instance, ABO blood groups, and how that influences severity and susceptibility.
Thanks, and do call me Jonathan. So I think the first thing to say is that the ONS have looked at this in quite some detail. And I think when they look at it, they come up with some quite clear messages that there are differences in mortality due to COVID-19 infection by ethnicity, and that they are picking up a consistent signal in Black and South Asian ethnic minority groups. Now, if you look at non-white ethnic minority groups as a whole, their risk of mortality is still higher than white groups. Now, it is very difficult to disentangle, and the science is really, I think, at this stage, not clear whether these are purely genetic susceptibility or partly genetic susceptibility, or whether, in fact, this is exposing the fact that there are disparities in terms of socioeconomic status in the UK by socioeconomic group, and that ethnicity, if you like, may be to some extent a marker for sociodemographic status and a propensity to have to live, not through reasons of choice, in households that are larger, where there is a greater degree of crowding, where there is a greater likelihood of onward transmission. And it could be that it is simply kind of all of this is kind of magnified. There are also differences in health status by ethnicity. We know that diabetes, for example, is a particular feature of South Asian ethnic minority groups in the UK. We know that diabetes is a risk factor for a poor outcome after COVID-19. And we know that sociodemographic status affects what we can afford to buy and how we live and eat. And that potentially then has an effect on obesity, which we know is a very big signal in terms of a bad outcome from COVID-19. We also know, for example, that it's much more likely that groups will live in kind of extended intergenerational communities in ethnic minority settings. So it's very, very complex, I think, is the short answer. But yes, there is a signal.
Clear response to quite a complex question. A follow-up question relates to younger generations, young individuals. It's clear that young individuals with apparently no systemic problems, any illnesses, do, if they catch COVID, can become unwell. Is there any scientific background to that? Do we understand that?
So people are I mean, this is a very, very new infection, a very, very new organism to humans. And so even though we're 2.5 years in, we are not even quite that, but, you know, we are really at the beginning of a journey to understand what determines pathogenicity in individual humans. And if you go back to, for example, the 2009 swine flu pandemic, you'll see that Peter Openshaw at Imperial College and various others identified the IFIT-M3 gene as a marker of susceptibility for a severe outcome to swine flu. Now, we're at the beginning of those kind of journeys, and people are just beginning to kind of pick out these markers, the genetic markers that might be a marker for severe disease. But I think it's likely to be multifactorial. And the straight answer is that if it were only as simple as being able to say, I'm young and I'm thin and I'm fit, therefore this is of absolutely no concern to me, then life would be fairly easy. But as clinicians will tell you, they see these young, previously healthy people picked out of the line by this nasty virus, and we don't know why. And a proportion of them end up on the intensive care unit, and a proportion of them die on the intensive care unit, and we don't know why.
Thank you, Sir Jonathan. Food for thought there. Perhaps a topical question to pose to you now. We have a large number of young adults in our student and workforce population. What would you say to them if they feel they're immune, having been infected with the virus over the past 2 years, and question the need for them to be vaccinated?
So let me kind of come at this 2 ways. The first thing to say is that we are now pretty sure that natural immunity, having been infected with COVID-19, lasts a while, but then declines, in the same way that immunity acquired through vaccination lasts a while, then declines. That's the first thing to say. So the idea that this is like measles, and that once you've had it and you've kind of got better, that's it for life, just kind of bring it on. I'm afraid it's not true. The other thing to say is that South Africa, as you know, their scientists identified the Omicron variant wave, and almost certainly did emerge in South Africa. And so we thank the South African scientists for being as open and as honest as they were, and front-footed in warning people. But this happened, and it was a massive wave of Omicron in South Africa. This happened just at the end of a very, very large Delta variant wave. And since South Africa has a rather poorly vaccinated population, we believe the seroprevalence of immunity to Delta at the start of the Omicron wave was very high, but it didn't stop the infections. And so it relates to one of your other questions, really, about variants of concern, about the question you sent to me was potential for vaccine escape. I think I want to rephrase that as the potential for immune escape. And it's very clear that immunity from previous strains is at best partially protective against Omicron. And depending upon how long ago it was that infection occurred, there could be very little protection left. Where we're getting to, I think, and I'm going to be absolutely straight about this, more and more scientists are saying it, and I definitely am in that camp, that probably for somebody to get to a point where they can kind of manage COVID-19, or on average manage it well as a kind of normal, survivable, non-serious respiratory infection, we think more and more they're going to need to be shown the spike protein, that's the antigen on the outside of the virus, 3 times, possibly 4 times. And we're picking up the evidence from that 3 doses of vaccine, including the booster, is really at the moment showing strong protection against a bad outcome from COVID, against severe disease, hospitalisation, about 85%. But in terms of 2 doses of vaccine, I'm afraid the data against Omicron now look like somewhere between 0 and 20% effectiveness in terms of stopping infection, and probably more like 40% in terms of stopping serious disease. So I think there is beginning to be something, I don't like magic numbers in science, but there probably is something that is a kind of threshold around 3 to 4 exposures to this virus before your immune system is suitably kind of perked up. So I think it is going to be possible in the future to construct an argument that says, if I've been infected with coronavirus naturally 3 times, then I'm at least as well protected as somebody who's had 2 vaccines and a booster. If I've had 2 doses of vaccine and 1 wild type infection, then probably I'm in broadly the same place as somebody who's had 2 doses of vaccine and a booster. So I think that's where they're kind of going to come to. The sciences and the data are just emerging on these points. I think they're going to get stronger as we get more and more data from a study we call the Siren study, which is thousands and thousands of healthcare workers in the UK who regularly give blood, regularly give specimens, and we know their vaccine status absolutely. And because they're being tested twice a week, we can kind of monitor their reinfection rates as well. So that's giving us very valid and valuable data on where I think this is going to settle.
Thank you. That's a very good picture for us to follow with. Just quickly, co-infection with flu, influenza. What are your thoughts about that and the response to COVID?
Yeah, well, we've certainly already seen with MERS, which is another coronavirus, as you know, that didn't cause a pandemic, but could be argued as a pandemic near miss, that when co-infection occurs with flu, the outcome is poor. And we've also already now seen with COVID-19 that co-infection with flu at the same time gives you a much greater likelihood of a poor outcome.
So
but one of the things I kind of say on that is that, and I think it's just an interesting point to kind of teach the students and the staff on, is that the unconstrained R of SARS-CoV-2 was certainly above 3 in the original Wuhan variant form, and some would argue is probably closer to 6 or 7 with the Omicron form. In other words, got a very high R. Now, the R with flu is probably around 1.2 to 1.5. Even pandemic flu, there are no kind of calculations that go above 1.8. So if you have lots of public health measures pressing down hard, then they press down hard on all respiratory viruses, not just COVID, because they're kind of blunt tools. And the first thing that breaks through those public health measures is the thing with the highest R, because it's got the biggest force of infection behind it. And so it is always going to be the case when we've got public health measures, if COVID breaks through first, flu is going to be breaking through a good way behind. And that's why we've had no flu in the last 2 winter seasons to speak of. And we have just a teeny trickle of it now. Come next winter, autumn 2022 into 23, I don't know where we'll be. Hopefully we'll be in a very good place, even better than we are now in terms of vaccines. And the government will not need to do any of these plan B or even worse type of kind of public health measures. And in that situation, I think flu will circulate alongside COVID next winter, and it could be quite challenging indeed.
Yeah. Thank you for that. That's very helpful. Can I move on to think about testing now? How effective do you perceive the lateral flow tests to actually be, particularly for the new variants?
Yeah. So one of the first questions I asked the UK Health Security Agency when the Omicron variant emerged was how good are the lateral flow tests? Will they perform as well against Omicron as they do against Delta, for example? But I asked the same question when Delta emerged, because obviously the lateral flows were originally designed to pick up Wuhan. And the answer back is from the UK Health Security Agency, is that nothing in the data tells them that these lateral flow tests are working particularly poorly against Omicron. Now, an equally relevant question is how well do the lateral flow tests work compared with PCR?
Yeah.
And of course, PCR is highly, highly sensitive and involves an amplification step. So basically, a PCR that's performed well can pick out a tiny strand of dead virus and give you a positive result. We know lateral flows can't do that because there's no amplification stage. But what Susan Hopkins, who's the medical director of UK HSA, tells me, and I do think this is right, is that if a lateral flow test is positive, it is pretty reliably identifying people who could be infectious to others. And in that kind of grey zone where a PCR is positive, but a lateral flow is negative, then you're more in the scientific realm of, yes, this person's undoubtedly infected because PCR is gold standard evidence, but the viral load is probably so low at that point in that person's illness, and it depends when the specimen was taken, but the viral load is sufficiently low for you not to be infectious to others. So I think lateral flows, in short, are a very good guide to whether you are likely to be posing a hazard to others if you are out and about.
That's very clear, Sir Jonathan. Following on from that, do you think we should be doing point of care testing prior to hospital admission or dental treatment?
I mean, there are lots of pros and cons for that. You have to be careful with lateral flow tests that when you get to a point where disease activity is very low in the population, then the propensity for false positives can become quite high compared with the propensity for false negatives. And so I think, I don't think I want to kind of make a call on that, because I think each clinical situation is different and each clinical situation is going to change according to the prevalence of virus in the population from which you're admitting the patients into your healthcare setting. But as a general rule, as I say, go back to the fact that lateral flows are very useful to determine if you're looking at somebody who is an infectious hazard to others.
Thank you, Sir Jonathan. Could we now move to the vaccination itself and the potential for adverse effects?
Yes.
Are there particular concerns about potential adverse effects with the COVID vaccinations?
So it's always the case that when you do clinical trials for vaccines, you pick up, because clinical trials are usually, 10,000 patients or less, you pick up side effects that are common. And that is why we can be very certain about side effects such as a sore arm. And we can be very certain about side effects such as feeling rubbish for a few days. That's not really a clinical term, but it is how people feel sometimes. Headache, chills, malaise, muscle aching. These are all kind of common, well-documented side effects, and not particularly specific to COVID-19 vaccines, but they are definitely present with COVID-19 vaccines. And I'm not going to pull a punch on that. I'm going to, say very clearly that, when I had my first jab, there was no doubt that within about 15 hours, I had a fever, I was shivery, I felt really cold and achy. It all passed in a few hours. So, yes, you do get those. But what people are more worried about and more concerned about, and I don't dismiss any of these concerns, are side effects that are rare that you cannot pick out until you've actually deployed the vaccine. There just isn't there isn't any other way to do that. You have to deploy it to millions of people, or in the case of the COVID-19 vaccines, well over 1 billion people. And then with good pharmacovigilance, you can start to pick out rare signals. And I think that the two that I would want to comment specifically to your students about are, first of all, the blood clot one, which I think we can say now is associated in some people, but incredibly rarely, with the first exposure to an adenovirus vectored vaccine that is either AZ or Janssen, Johnson & Johnson, as currently exist. But my reading of the data is this is very much a first dose phenomenon. But that is why quite early on in our programme, the JCVI said that those vaccines should not be used in people under 40, because the risk of that blood clotting is much higher in the young than in the old first. Yeah. Though I would say that there are members of my family who are significantly younger than I am, who've received 2 doses of the AZ vaccine. Now, the alternative for the under 40s has been the messenger RNA vaccines. And, there's been too much ill-informed talk about messenger RNA. It sounds genetic, it sounds DNA, it's all of that. But, there's messenger RNA in almost every human cell. And it's really a basic building block of how our cells work. So there's nothing that's sinister or fancy about it. But with the messenger RNA vaccines, we are picking up in younger people a signal of myocarditis, which is inflammation of the heart. So I'm not going to pull a punch there. That's what it is. But it is vanishingly rare. Again, down into incredibly small numbers per million doses given. But there are now studies that are showing very clearly that if you get COVID-19 wild type infection, in other words, you don't get vaccinated and you catch COVID, then your chances of myocarditis are somewhere between 4 and 6 times higher as a result of the wild type infection than from the vaccine. So this isn't a risk. The myocarditis risk isn't a risk you can kind of avoid by avoiding vaccines. Because with the Omicron variant, if you're not immune to this, you're going to get it. It is so infectious. And therefore, you're going to have to kind of make your date with the numbers in terms of the risks of myocarditis at some point. So you just have to choose whether you want to control that exposure through a known risk with vaccines, or whether you want to run a higher risk with the wild type infection. That's what we're actually talking about there.
That's very interesting. Thank you. It really is.
But, I just think the data in terms of how much less likely you are to be seriously ill and plumped into hospital or die after vaccination, after boosting now in particular, speak for themselves.
And in the rare eventuality or possibility of an adverse effect occurring, a question we've been asked is about liability.
Yes.
Where would that lie?
Yes. So there's something in the UK called the Vaccine Damage Payment Scheme, VDPS, Victor Delta Papa Sierra. So if anyone wants to Google VDPS, it's a government-run scheme, and it covers all approved COVID-19 vaccines and lots of other vaccines beside. Basically, it's a kind of no-fault scheme, compensation scheme. It gives a one-off tax-free lump sum of £120,000. If anyone can suffers a severe disability as a result of a vaccine claim, and the assessment is that on the balance of probabilities, vaccination caused the disability. So that's the kind of acid test, if you like, and claims need to be filed within 6 years of receiving the vaccine in question.
Great. Thank you, Sir Jonathan. Now, thinking about the vaccine schedule and the mandate, which has been causing a lot of concern within the NHS and also in our staff population.
Yes.
As you know, we have a lot of patient-facing clinical staff within the Dental Hospital and Dental Institute. And on the top of that, we've got academic, research and professional services support staff with undergraduates from both at home and overseas and postgraduates as well. Which of these groups do you feel are included within the mandate? It's a big question within the hospital at the moment.
Yeah. So as I understand it, John, I'm going to have to read this. The question, first of all, is the individual deployed? It doesn't say employed, it says deployed for the provision of a CQC regulated activity. So if you're within the umbrella of a CQC regulated activity, then that can include face-to-face contact with patients or service users in their roles. So I think that does cover quite a broad spectrum of people who are entering into and working in premises that are that provide a CQC regulated function.
Thank you. That's very helpful and very clear.
Yeah.
There's been, this might be a little bit political, but there's been a lot of concern with regards to vaccine hesitancy within clinical staff, which potentially could result in termination of NHS employment, certainly in England, and with the result that maybe people are considering moving across to the other countries within the United Kingdom. Yeah. Worries have been expressed in our questions about this putting extra pressure on the NHS, but also on personal lives. And I wondered if you could sort of shed some light on that for us.
Yes. So I'm very clear that as a health professional, that physician in my case, the GMC Duties of a Doctor booklet, document, clause 29, says I should be vaccinated against, I can't quite remember the words, I'll have to paraphrase them, against infectious diseases which could pose a risk to me or my patients, unless I have particular medical contraindications. So, and the Association of Medical Royal Colleges has said something very similar on COVID-19 vaccines. So I see it as my professional duty and responsibility to have COVID-19 vaccines. I don't distinguish between them and my professional responsibility if I'm going to do an exposure prone procedure to make sure that my hepatitis B status flags as immune. So that's how I frame it, and that's where my personal arguments stop. Is it a matter of data that if we have a fully vaccinated healthcare workforce, we will have safer premises? We will indeed, if vaccines prevent infection, and they do. Yeah. It is a secondary order question about whether they prevent transmission if asymptomatically infected, because actually if they prevent infection in the first place, well, if you haven't got infection because it's been prevented, you don't shed anything. So that's the end of that one, if you like. So there's always going to be an effect from prevention of infection. That's kind of where I start out on that. So will we have materially safer premises if more of us are vaccinated? Yes. How the government chooses to set policy to achieve a highly vaccinated population is a matter for government. This is a matter for politicians and policy. It is not a matter for doctors. But on the science of, if none of our, take the extreme, if none of our doctors, nurses and dentists were vaccinated against COVID, the health service would be in a pretty terrible state right now, dealing with the amount of Omicron infection it has to. The converse is that the maximum number of healthcare workers vaccinated doesn't take us to a place of absolute safety, but it gives us the best fighting chance of being there. So I can always say that to a politician or to you, that is a material fact on the kind of power of numbers, as it were. But how you get there and how you decide to implement policy is a matter for politicians.
Okay, thank you, Sir Jonathan. A quick question about exemptions, though, which has been raised. I presume that relates to anaphylaxis or allergic reactions to the... It
can relate to anaphylaxis or allergic reactions. It can relate also to, I believe it can relate to properly documented psychiatric illnesses that are related to specific phobias around needles and sharp objects.
Thank you very much indeed. And then just to round off, talking a little bit about vaccine hesitancy, that's been perceived to be a significant barrier for some people in terms of uptake of the vaccination. What strategies do you think would help with that and sort of addressing that? Because that obviously would be really, really great to undergo.
There are always a good proportion of people who are unpersuadable. They would, it doesn't matter what the government says, they're not having a vaccine. And, that those people are those people. But you're right, most people are not in that camp. Most people are hesitant for one reason or another. And what's important is that they have access to trusted professionals who they trust, not necessarily government figureheads or people associated with the government, even though I would be quite vociferous in defending the fact that I'm not a government figurehead. I'm an independent advisor to government. But, they've seen me on TV, therefore maybe some people on government, I don't know. But people should have access to somebody who they trust, who is qualified to give them appropriate advice and to discuss their concerns and to have those concerns met with a rational discussion where there isn't a sense of ridicule or blame and where this can be addressed with facts. That's my view, basically. Yeah.
That's fantastic. Thank you so much. We've overrun a little bit, for which I apologise. It's been fantastic talking to you and learning about that. Are there any other points that you'd like to make to our student body and to our staff?
No, I mean, I'd like to thank the staff involved in patient-facing care or support activities, whether that's been directly caring for patients with COVID, keeping the rest of the NHS going, or taking part in the vaccination service. This has been the most incredibly difficult 2.5 years. Almost certainly the biggest global public health challenge of our lifetimes. I don't pretend it has been easy for any of us. And I think wherever we sit or happen to have sat in the system, either through choice or by fate, as it were, at the time when this happened, I appreciate everybody who's put their weight behind trying to get on top of this. The Omicron wave is still very active, but I think there are 1 or 2 green shoots now, and I'm hopeful that in the next few weeks and months, things will start to look a whole lot better.
Thank you. Thank you, Sir Jonathan. I'll hand you on to Professor Coulthard.
Hello, I'm Paul Coulthard. I'm Dean of the Institute of Dentistry, and my job is to thank you, Sir Jonathan, for giving us some of your time. But I can't help but just quickly go back to your recent questions, just for clarification. Because you're right, dental schools, ours is very typical here at Queen Mary University of London, in that we have in an NHS facility, university employed staff. So going back to what you just mentioned about vaccination and its mandatory requirement in facilities that are inspected by CQC. So effectively, that is the responsibility also of the university as the employer to ensure those staff working in the facility are vaccinated. Is that correct? Yeah.
Well, I think probably the responsibility would fall through their honorary contracts with the NHS.
Yes.
But I'm not really an expert in the kind of the legalese of quite who holds the responsibility for clinical performance. I think it's through the honorary contract, but I'm not quite sure.
Okay,
but I think this applies to health professionals, you know, and that's what it's meant to do.
Yes, absolutely. Okay, thank you so much. So thank you, Sir Jonathan, for giving us your time. You're an incredibly busy person. We thank you for your time, and we thank you for all the work that you're doing and for the great communication that you offer our United Kingdom. We're delighted. So thank you so much. We really appreciate it, and we'll let you get back to your day job with your busy time ahead. Thank you so much. Thank you.
Thanks, Paul.
Bye.
Hi, everyone.
Bye.